मुझे आ नहीं रहा है, है ना? नहीं नहीं, मतलब जब खत्म हो जाएगी ना प्रेजेंटेशन। अच्छा।
ଏ ବୁଟଟା କାଲି ରାଜି କରୁଛୁ ଏଇଟା वो चीजें की जा सकती हैं। ठीक है।
तो कुरेसा, कल से नहीं मिलेगा तुम्हें टीवी देखना।
अंदर रह लेता है, बाहर भाव करता है, करता है, पता नहीं क्या है आता है।
रहता नहीं है, उसको
बन गया।
पसंद नहीं है।
आज हुआ क्या, पटरी से गाड़ी उतर गया।
परसों आई थिंक वो था।
Good evening, sir. So you are muted.
Now can you hear me?
Yes, sir.
Hi.
Hello, sir. So Dr. Rakesh, sir, he said that he will present the laryngoscopes and the laryngoscope first because he is the basic topic followed by yours.
Okay. This is the advanced topic भाई मेरा तो basic है. राकेश जी. राकेश unmute.
Mine is more basic than yours. I spoke so many times at Tata, and so finally he said you include few videos also. So I said okay, I'll include one video which I like the most. So because
Good.
it's a difficult laryngeal exposure. So
Yeah. It's very important to understand that. Yeah.
it's a very popular series, Mahamana. I have attended thyroid. It's all like an update.
Yeah. We are just the fillers, Rakesh ji.
Pardon?
We are the fillers.
No, you
No, this
you
is
are
a
the
special
master.
series topic, sir.
Thyroid is like because in academic group also it is very difficult to keep the pace of discussion.
Yeah.
And suddenly night I got a call from Nupur that you have to be part of it. I said I have such a long OT list. How can I be part of it? It's very difficult to keep.
Yeah. It's not easy.
It is not.
The whole day you can't be free and doing this.
And suddenly night time you get a call like. So finally our startup is registered now.
Okay.
So hopefully we are 2 projects more, and one we have got a patent, so waiting to apply it.
Very good. I think that's just going to once it takes off, you will have a lot more to offer.
Yeah. One on breathing sound also. So that we are working on collecting data and analysis by IIT professors.
This is in the IIT in Lucknow?
Kanpur. There's no IIT in Lucknow.
Okay. It'll come soon.
No. Shall we?
Yes, sir. So good evening, everyone. Welcome to Mahamana case discussion series, and the theme of today is early laryngeal cancer. And for this, we have two very eminent speakers, and we'll start with the first one, Dr. Rakesh Srivastava. He's an enthusiastic and very passionate laser surgeon based in Lucknow, and he'll be speaking on laryngoscopes and laryngoscope.
How can I share it? Actually, you have to disable it.
Yes, sir. Now you can share.
Good evening, everyone. Thank you, Dr. Asim, for giving me this opportunity to share my thoughts and share it with my other co-speaker, who's very well experienced and senior in this field, Dr. Prathamesh Pai. So my talk is on laryngoscope and laryngoscopes. The results of transoral laser surgery depends on multiple factors, and one of them is important is the laryngeal exposure. So the results of TLM is on laryngeal cancers is dependent on intraoperative diagnostic workup, experience of surgeon and team, post-operative follow-up, preoperative diagnostic workup, imaging, patient selection, and adequate laryngeal exposure. So adequate laryngeal exposure is one of the important, the pre-operative assessment of patient for a good results of your surgery. The history goes back to one of the path-breaking article in Annals of Otolaryngology, published way back in 70s, which describes about the suspension microlaryngoscopy in a voice position, which we still follow the same principles for laryngeal exposure. This term of laryngoscore is coined by one of the eminent laryngologist and pioneer in this field, Dr. Cesare Piazza from Italy. And he has given 11-point score on preoperative clinical predictors of microlaryngoscopy.
वो एक सेमिनार देख रहा हूँ.
The laryngoscope is based on Boyce Jackson's position, and they have used is the Dido laryngoscope for it. And it basically evaluation of anterior commissure, and because anterior commissure is one area where it is a heterogeneous area, difficult area to expose even with a good laryngoscope. So it's a 11-point score considering inter-incisors gap, thyromental distance, teeth, trismus, macroglossia, micrognethia, previous treatment, mandibular prognathism, neck extension, and modified Mallampati score, and BMI. So this is 11-point score in which they have divided into a score which is less than 6 and which is more than 6. So every description of each of these factors are added into it, and it came out to be 11-point scale. And so coming to one by one on each and every important factors, that is inter-incisors distance of more than 4 centimeter is a 0 point, less than 4 is 1 point. Then thyromental distance of more than 6.5 is a normal and easy intubation and easy for laryngeal exposure, while it has given me 0 points, and accordingly 6 to 6.5 is a 1-point score. Then upper jaw dental status, edentulous is given 0 point, partial edentulous 1, normal teeth or a prominent is given 3 points. 0.4 is trismus, 0 is absent trismus. Then macroglossia is there, and mandibular prognathism and micrognethia are divided into 0 and 1 point according to the presence or absence of it. Then the neck extension, again, more than 90 degrees 0 score if it has got a good extension, because normally we go for a voice position, extension at atlanto-occipital joint. Less than 80 to 90 is 1 score, and less than 90 degrees score 2. The BMI of less than 25 is a good case with a thin neck, less of fat. More than 25 is a 1-point score. Now, modified Mallampati score is considered into it, so in which the tongue is inside the oral cavity, and then 0 point class 1 is given is for when you can see the margin of the uvula. Class 2 is when you can't see the edge of the uvula. Type class 3 is when you are not able to see a part, the whole of the uvula and the part of the soft palate. And when you are not able to see whole of the soft palate, part of the hard palate only you can see it, that is class 4. So this is again been divided into 0 point, starting with 0, 1, and 2, and 4, 3s. Previous treatment, the patient undergone any radiation, so it will be very difficult for a woody larynx or woody neck, and in that cases the mouth opening will be restricted and extension will not be possible at atlanto-occipital joint. So they again be divided on these parameters, again be divided into various classes. Class 0 is anterior commissure visualization by large bore laryngoscope. mainly the dido laryngoscope has been used in Boyle's external position without external counter pressure. That is, third hand has not been used. Class 1 is when anterior commissure visualization by large bore laryngoscope with Boyle's external position with external laryngeal counter pressure. Class 2 is again in flexion position, that is flexion of chest or neck over the chest, and it has not been possible to do the extension of atlanto-occipital joint, that is flexion position. Class 3, when you have to change the laryngoscope to a small bore laryngoscope in flexion position, and class 4 is impossible visualization of anterior commissure. So score of each parameter were added ranging from 0 to 17. So from 0 to 17, if the score is less than 6 is a good laryngeal exposure. That is, in 94% of cases, you may be able to see the anterior commissure easily, but you might not be able to see in 6% of cases, even with the score of less than 6. In difficult laryngeal exposure, class 3 and 4, the median score is more than 6. And in these cases, you will have a smooth ride in 60% of cases, and 40% you may face the problem. So coming to the point that why we are discussing about these scoring system, why because your results of transoral laser surgery will always dependent on, especially if you are taking a case of anterior commissure lesion. Around 14% of cases with T1A, T1B with anterior 1/3 of focal cord and T2, T3 glottic disease may have been performed in a suboptimal or a impossible conditions. So these cases you have to keep a close follow and look for any residual disease or recurrence of disease. And secondly, if you are sending it for histopathology, you should mark it properly. Then point missing in these is 11-point score, which is been mentioned by Piazza, is very important. One point which is thoramandibular angle. That is, if it is more than 120, it is, and if it is more than 130, is a difficult laryngeal exposure, because you will not be able to get a good atlanto-occipital extension into it. So obesity, neck, short neck, retrognathia, and other factors which are there. Advantage of laryngoscope: easy, quick, reproducible, and cost effective. It is also helps in patient counseling and difficult exposure, because we can explain the patient about the end results. There's another article which is similar to that, almost published in the same time. That is from CMC Vellore, that is difficult laryngeal exposure and microlaryngoscopy. And they have also used almost the same score and defined DLE as inability to visualize anterior commissure. And they have also used a Cormack-Lehan grading also. So I'll just show you one the video clips where this was a case of a revision anterior commissure. So a small lesion was left out. So this was the second surgery was done. So grade 1 is when you get a full view of vocal cords, and grade 2 when you get a partial view of vocal cords, anterior commissure seen only with the external pressure. That is either you are pressing, the third person is the assistant is pressing over the neck, or you are using a cross strap over the neck to look for the anterior commissure lesion. Grade 3 when the anterior commissure not seen even with external pressure, and grade 4 only 1/3 of vocal cords can be seen with external pressure, and grade 3 and grade 4 are very difficult, and you are able to see only the posterior part of the vocal cord. So in this, the third hand was used very effectively. And once I'm finishing off, after giving a mop there, and this type of dissection only be possible if you have a good assistant who can give a good exposure to the anterior commissure. Like this. Now you can see the external compression was removed, and You can see only the middle part of the cord and the posterior one third of the cord. This is again a lesion which is a transglottic and arising from the anterior commissure. Primarily, we don't see these type of lesion very rarely, because most of the anterior commissure lesion, they arise either from the one cord or it crosses on the other cord. So this patient was having a lesion over the anterior commissure. CT scan doesn't show any involvement of the cartilage invasion, but it was going infracommissurally. So exposure requires normally what I usually do is I first remove the part of the false cord above the growth, supracommissarily near the petiole. And once I get a good exposure of the once we open the tumor, and then we bring down the tumor from above to down. So it was supracommissural extent was not that much, but infracommissary it was just a superficial spreading growth. So not all lesions like T2 are same, because T2 maybe T2A maybe have got a superficial spread rather than a deep invasion into the muscle plane. So bringing down the tumor from above, the role of the assistant is very important. Removal of ventricular fold is very important to have a lateral look into the anterior paraglottic, because anterior paraglottic space and the posterior paraglottic space, there are two spaces which are very important for, but we are talking only about the anterior commissure. So once we reach to that lateral part, that is pericordium, where the pericordium is there, so then we start dissecting it using this black section, which we use it for laser surgery, and bring down the tumor. So this tumor has been removed as a piecemeal. Now we can see the inferior border of the thyroid cartilage. So lateral dissection, first the superior dissection, then the lateral dissection. The inferior dissection will come at the end. Because that is a three-dimensional, sometimes very difficult to look where your area of dissection is. And when you start putting down the tumor, you will know that exactly that how much. And the feel of the laser is very important, and the magnification is very important. The maximum magnification, you should use it once you are doing these type of. So this is the one side, then we are doing on the. So this is over the cartilage. Now this, I got the pericordium there, so I can do the dissection using a suction catheter there. Bring down the tumor. This is the inferior border. This area sometimes bleeds. Almost more than 2 millimeter of safe margin. So continuous irrigation also I use it to have a less of charring, and I usually use a blade, but small blade. But in Tata, I saw Dr. Prathamesh use a AccuSpot. And we keep the duration of fire is 0.05 seconds so that we are able to do it at a faster rate, faster pace. So part of the muscle, we are trying to preserve it because, and now the inferior dissection is very important, looking at from pulling the tumor up and looking at the inferior border of the, to have a safe margin of. This is the final look using a telescope. And then using a marking with the. So so laryngeal exposure and margin in glottic cancer treated by transoral laser surgery, in which Piazza analyzed his own cases of 126 patients, and he has divided into two groups, that is class 0 and 1, and group B, which is class 2, 3. And what he has observed is there's a positivity rate of surgical margin is higher in group B. So percentage of positivity in group B is higher, that is 41%. So lesson learned is DLE, difficult laryngeal exposure, preoperative counseling is very important, experience of surgeon, anterior curvature is the critical area, anterior cord or bulky tumor may be a problem, and difficult laryngeal exposure in 14% cases. Now regarding the types of laryngoscope, the position of the patient in transoral laser surgery or any microlaryngeal surgery is very important. So positioning of a laryngoscope is very important, and how much force applying it, what your position of your laryngoscope is very important. You should not go too close to the lesion. You should not be too far away from the lesion. And if it is the right side, left side, you can adjust the laryngoscope. Either you can use a telescope also to look into it. So for an adult patient, the position of the patient should not be like this. This is the wrong position. The exact position is what has been described, and what we are using it in our practice is raising the head end of the patient to 15 centimeter, either by a pillow, or if you have an adjustable head end, you can flex the head end of the table to that extent to make it a 15 centimeter. There should be a flexion of neck over the chest, and there should be an extension of atlanto-occipital joint, and the force of action should come from the surgeon's lower leg. So muscles, and you should the insertion will be more first posteriorly, and then you lift the larynx like this. So holders and suspension, what we use normally in our practice is Levick lens saucer scope, which are normally, we have seen it in college stores are having it. But nowadays, for last 4 or 5 years, I have been using this gallows system, which you are seeing it on the right side of the picture. So this now we have modified version of gallows, which has been manufactured by Indian manufacturers in India, and I've been using it for more than 5 years, and with good force, because here the force of pressure is only on the mandible, as compared to Levi chest support, where the force is more on the maxilla, and it is easy to adjust also. Now coming to the type of laryngoscope, normally during our MS time, we used to use a lens saucer operating laryngoscope. There are many Indian companies which manufacture these laryngoscope, which are very good and universal and mid-glottic work. It is good for it. Now we have added few more in our other practice also for pediatric surgery and for adolescent patient. We used different type of scope. This one is a partial laryngoscope, which has been used in pediatric patient to visualize the larynx. Normally we use 10% spray. And this is my modified version of clean saucer, which I use it. This has got 6 holes on the back, 2 on either side, because this one I use it for when I'm using a high flow oxygen for posterior dissection. So once you block the glottis, you will not be able to ventilate the patient through the blocked glottis. Once you put the laryngoscope there, so this I have designed it, and so that the flow of oxygen remains through these holes, and we are able to ventilate the larynx. And the maximum which I have used for with this laryngoscope is around with the relaxant is 40 minutes. So without a tube, you can continue to operate in especially the posterior part of the larynx, whereas sometimes very difficult to use it, especially if you are doing a cordotomy for bilateral cord palsy or some other procedure which are doing it for posterior cord. So this has been published by me, modified clean saucer for high flow nasal cannula. There are other laryngoscope like Verda distending laryngoscope. I have not used it very often. Rudert, I have used it, but this is also from Karl Storz, and it gives the triangular view of the, but it is not, it's supposed to give a good exposure of anterior commissure, but is not very effective, as we can see in my own clinical practice. Lindom again is a very good laryngoscope for panoramic view, especially for supraglottic work like soft tissue tumors, for malignancy also. It has got a wide proximal opening and also wider distal opening to give a good panoramic view. And it can be fixed over the goes into the vallicula also. You can see the whole of the epiglottis if you are doing a dissection of supraglottic cancers. Another which I've been using also for pediatric airway also for this laryngomalacia and other supraglottic surgeries. Steiner is very good laryngoscope for because it has got a plume sucker into it. It has a modification with a side arm, like this is been used for to protect and to prevent the tongue to come into the field once you are doing a laryngoscopy. So it has got a side blades like this, and which prevent the protrusion of tongue from the side of the laryngoscope. There is another modification of this combining this one, the Lindom laryngoscope, which has been combined with this type of laryngoscope. So this part is a Lindom upper end, and there is a distal end which can be expanded like that. So this is also very good because it is giving a very good area for distal dissection. The other laryngoscopes, like this one is a Hollinger's, which has been used for below the cord lesion also, and it has got a slotted end, and it is adjustable also. So it can be used if you are using a Lindenberger needle carrier, you can use a Lindenberger needle carrier with this Hollinger slotted laryngoscope. But otherwise, in my practice, I use simple our anesthetist Macintosh laryngoscope if I have to use Lindenberger needle carrier for if I have to fix a keel there at the glottis for to prevent any synechia formation. And this is the workhorse for laryngeals, especially for anterior commissure, that is Dido laryngoscope. It also comes in 3 sizes, but for Indian population, the medium size is the best one because it suits Indian population, adult population. And now I've got the smaller one also, that is for pediatric, but this is basically for the adult, and it gives a very good exposure for the. So these are the various views you get from the Rudert, Jacko, Dido, and Verda laryngoscope. But for anterior commissure, the workhorse is basically Dido or the clean saucer laryngoscope. So narrow bore is also there, like a hypopharyngoscope. You can use it, or you can use the Havas laryngoscope with the optical with a telescope into it. That gives 15-degree telescope at the proximal end, which can give a good exposure to the anterior commissure. So coming to the end of my last slide, that is success of microlaryngoscopy or transoral laser surgery is dependent on pre-operative assessment, the time to evaluate, that is laryngoscope, and the instrumentation, which is very important, that is types of laryngoscope and types of suspension system which we will be using for such type of surgeries. Thank you very much. Dr. Asim?
Thank you so much, sir. Thanks a lot for the excellent talk. And for the next talk, I'd like to invite Dr. Prathamesh Pai. He does not need any introduction for this crowd specifically, and he's a great mentor for all the ENT surgeons and head neck surgeons. He's a senior director head and neck surgery in Punishlok Head Neck Cancer Institute in Mumbai, and he'll be speaking on philosophy of early transoral laser microsurgery in early laryngeal cancers.
Thank you, Asim. I'll just wait for this screen to be shared. Hello?
Yeah, sir, are you able to share?
No, I'm not. I think Rakesh ji, can you stop sharing? Hello? Hello?
I'll just,
Okay.
yes, sir.
Host this
Now,
April.
now you can share, sir.
Okay. Can you hear? Can you see now? Yeah.
Yes,
So,
sir.
Asim, thank you for the invitation, and I appreciate the opportunity to speak to you on what I feel about transoral laser microsurgery. Way back when we started doing these surgeries, we realized that there are a lot of misconceptions regarding transoral laser surgery. And when we started having the laryngeal laser course from 2014 onwards, the first person who came to us for this course was Professor Paretti. And I have been in touch with him for almost 2 decades from 2004. And I've learned a lot of the laser procedures from him. And when we started doing our own course, Asim, if you remember, he was instrumental in actually developing the kind of instrument wherein we would give the participant an ability to use a pig larynx for understanding how to use the laser. So basically, we need to understand that the transoral surgery is something that we need to endeavor to do. The use of laser or a cautery or a robot follows through. It is just a matter of using a device along with this access. You heard from Dr. Srivastava how we can actually get a very good access within the endolarynx. But try and understand, and for the youngsters in the audience, we need to understand how to enter into this space through the oral cavity, which is a natural orifice. Now, getting all these instruments in, getting your suction, getting your laser, getting your electrocautery makes a big difference in that small orifice. And especially in Indians, where the mouth opening is poor, not only because of the poor dental hygiene, the bad dental architecture, the oral architecture, the submucous fibrosis, this creates a big challenge. So whenever we endeavor to apply the transoral route for accessing patients, especially early laryngeal cancer, we need to first evaluate how we are able to visualize the larynx. And you heard from Dr. Srivastava's talk how various different laryngoscopes can be used in order to reach this endpoint. Dr. Piazza and the group from Brescia designed the laryngoscope with the idea that you will be able to estimate prior to treatment how you will actually complete your procedure. So the laryngoscope goes towards understanding whether you will be able to complete that procedure in that patient. Now, when you use a laryngoscope and you use a direct laryngoscope, you are actually accessing the insides of the oral cavity. You can see the palate, you can see the tonsil, you can see the posterior pharyngeal wall, you can see the base tongue, the supraglottis, hypopharynx, and then the glottis. So there is a lot more you can do with a transoral microscopic surgery. And then when you add microscope to it, you can get magnification, you can get illumination right down into this. The key to understanding this process is to relearn anatomy. All of us learn anatomy from the skin inwards. We know how to access the structures of the endolarynx from outside to inside. What we have to learn to do is relearn anatomy and understand how the vessels, how the nerves, and how the structures come in that order from mucosa to exterior. And this will actually help us understand how we are going to resect these lesions. You saw how Dr. Srivastava beautifully resected the anterior commissure. It was possible because he now has a complete understanding of where is that mucosa, where is the vessel coming into the mucosa, from which structure he can actually dissect. So it is very important that before we actually learn how to do these procedures, we relearn anatomy from within out. The next most important thing is to understand that a transoral route will actually help us maintain normal physiology. With minimal exposure, with minimal access, and with minimal handling of the tissue, we can have a lot more to do with maintenance of the physiology. When we go from the skin into the larynx, we will actually cause more alteration of the anatomy. We can have alteration of the vasculature and the neurology, and this will actually change the patient's physiology. So transoral access not only gives you a direct access, it also maintains the physiology of the patient to the maximum. And now, lastly, is the healing. When you look at these patients, you resect the mucosa, you resect some structures like muscles and nerves and vessels, and you will allow the natural secondary intention healing, which will improve the patient's quality of life. So a transoral microscopic surgery not only allows you good visualization, it allows you to do it under magnification, it maintains the physiology of the patient and will not require any secondary flaps for healing. So there is a complete different method of treatment with the use of a transoral access. Now, why use laser as a tool? Now, we want to reach within and we want to resect. Now, laser is a very good tool in order to cut tissue. Now, laser, the most commonly used laser for us is a carbon dioxide. And with the current technology, you can see that you can have a microspot or a AccuBlade, which is 250 microns. And that is precision cutting. So you can actually hit that beam onto the tissue and stop. So you can actually create only a 250 micron spot. Now, when you have a device which just will transfer energy to a mucosa and stop. What happens is the prevention of thermal damage. And all that we are doing today is trying to do with minimum damage to the surrounding tissue. So laser scores over all devices currently available because we can actually prevent the lateral thermal damage with the help of the laser, which is a free form. So when I use a micro manipulator along with the microscope, we are actually just manipulating a free beam which will hit the tissue and move along with the joystick that we have. Alongside, in the last few years, in 2015, we got the AccuBlade technology. And what this does is allows you to move the laser beam from point A to point B without having to move the joystick. So you saw how Dr. Srivastava had an AccuBlade, so you can define it as a 1 millimeter, 2 millimeter in size. And then you can actually use that robotic AccuBlade technology to move the laser beam from point A to point B, which will move at the surface at a defined speed and cut tissue. So the scanning technology allows us now to cut at a faster rate, at a more precise rate, in a precise direction, and allows us to remove that tissue without much problem. Now, many times we may want to reach into areas, but the patient's mouth opening, patient's ability to open the jaw is poor. Now you can use a glass fiber, which comes now with the carbon dioxide technology, which allows you to go into these hidden areas. So we will use the fiber technology to use remove tissues in the subglottis, in the trachea, and if the patient's mouth opening is poor, in the oral cavity. Now, having said all this, we remember that the laser is a carbon dioxide laser has limitations. It will not control hemorrhage from vessels which are more than 0.5 millimeters. So that means that you may have to account for some other form of hemostasis when you use laser. So for supraglottic resections, hypopharyngeal resections, and even glottic dissections, which are in the false chord or in the subglottis, you will require some other forms of hemostasis, usually with electrocautery. Now, where do I see the application of this in early laryngeal cancer? We all know about the barriers of spread. We know that in the endolarynx, there are the supraglottis and the subglottis, which come from different enlarges. That means the blood vessels, the tissue, and the nerves can be actually separated out, and because they are naturally protected by the tissues. We also know that the blood supply in the glottis is less, is poor. The lymphatics are sparse. So there is not a possibility that you would have a spread of the tumor into the lymph nodes or into the distant sites early on. So actually the early laryngeal cancers lend themselves to resection with the transoral route. Before we head the path of doing laser resection, we need to evaluate the lesion very carefully. So I urge all the colleagues to actually do a proper microendoscopy and use various methods to understand where is that disease on the vocal cord. Is the vocal cord freely mobile? Is it rolling properly? Is a lesion on the mucosa or is gone into the muscle? What is the extent? Is it involving the entire cord or is limited to one area of the vocal cord? Is it crossing midline at the anterior commissure or the posterior commissure? And does it really have involvement of other structures? Is it going into the paraglottis? Is it invading the anterior commissure? Is it invading the interarytenoid tissue? Now, we have learned a lot of our anatomy, actually studying the microangioscopy, and then going back and seeing the CT scans. The mobility of these structures is key. So if you have seen the last few years, a lot more about understanding about the uh, position of the lesion and its relation to the arytenoid. Now, we were also concerned about whether there's a mobility of the vocal cord and the mobility of the arytenoid, and if there is a difference between the two. Now, when I see a vocal cord and I think it is immobile, I will actually now see, is the vocal cord moving or is the arytenoid moving along with the vocal cord? So if the arytenoid is not moving, we need to understand that this is no longer a early laryngeal cancer. I urge you all to read Professor Suko's article, wherein they looked at how the arytenoid gets fixed. So if you have a lesion that is causing fixity of the arytenoid, you may have a true T4 on hand. So the golden line, as they say, drawing a perpendicular from the arytenoid to the thyroid cartilage. If your disease is anterior to it, it is worth resecting. If your lesion is posterior or lateral to it, you know that this is a more vicious disease. So assessing the mobility is very important. I always use a suction tip in order to assess the mobility of the arytenoids. And I use a submucosal infiltration in order to know what is the depth of this tumor. Is it actually remaining on the mucosa or is it going into the muscle? Imaging is very important, and only if there's a mid-cord lesion, which I can see all around, will I not do an imaging today. I would urge all of you to use a CT scan and ask for a high resolution CT. Remember that the CT scan technology is now possible, and the multi-detector CT scans give us a 0.63 millimeter cut. And ask for the DICOM files, see the scans yourself, and assess where is that lesion in the vocal cord and around the vocal cord. We know that all this resections of the vocal cord, if done properly, can give you fantastic outcomes. We have seen, you saw Dr. Srivastava show the Paretti's articles. So they published about their series of 500 patients, and in T1, T2 cancers, when they were able to do a transoral laser resection type 1 or 2, wherein only the mucosa or the mucosa and the submucosa up to the lamina propria was resected, the patient's voice outcome was as good as a normal patient. So we need to know that, can I offer this to my patient? At the end of my surgery, what's going to be the patient's outcome in terms of voice, in terms of oncology? So we have established and well established beyond doubt that laser scores over radiation, because you can actually control the resection and you will not damage the contralateral cord. But it is incumbent on us to understand that if I do a surgical resection, I will ensure the patient gets a good voice quality. If you feel that you're going to go beyond the muscle, you're going to go into paraglottic space, you need to counsel this patient that he will have a breathy voice. And in that context, you might want to offer the patient a transoral, offer the patient external beam radiation rather than a transoral laser surgery. Now, when we have the laser with us, then many times we have seen patients come to us where they have undergone a resection, but it is not actually a resection, it is fulguration. So you need to understand that I can either burn off the tissue or I can resect it. And today you need to understand that resection is what we need to do with the laser. You should not fulgurate the laser with the laser because you're not actually removing the tumor. At the end of your procedure, you should be able to actually resect that and send that the specimen for evaluation pathologically. Oftentimes, we discuss that this lesion is right in the middle, what we call as a muscar lesion. should I go ahead and remove it? If you go ahead and remove it, ensure that you get proper margin. You need not more than 1 to 2 millimeters of margin on the vocal cord in order to ensure that you have done an oncologically safe resection. So should you want to resect it, please resect it with a proper margin of 1 to 2 millimeters. You have to ensure that you don't have to go back in, or the next surgeon doesn't have to go back in and worry whether there is any tumor left behind. Please do not do debulking, because debulking will damage the patient in more ways than one. If you debulk the tumor, the next surgeon will not be able to assess what was the exact spread of the disease. Not only that, you will damage the blood supply to that tumor. If that patient now undergoes radiation therapy, this patient will have a poor outcome because it is a hypoxic zone. So please understand that there is no such thing as a tumor debulking. You should do the surgery so that it is the only modality of treatment. There are various methods of treatment, and in early stage cancers, if you opt for laser, it should be the only treatment you'll give this patient. You need to understand there are lesions which you may not want to treat with laser, and for various other reasons. And radiation therapy is a very good option of treatment if you are not trained, if you don't have the equipment, or the patient cannot be accessed with this transorally. These are some of the indications for doing laser resection, and there are limitations. Your limitations can be your experience, and there's no amount of harm, more harm you can do to the patient if you do not accept that these are your challenges. So if I want to treat this patient and I cannot access it properly, I should know that this is not a good case for doing laser resection. Early on in our series, we were doing only the mid-cord lesions because we knew that we could not resect it completely if it had gone into the anterior commissure. It took us almost 4 to 5 years before we could start doing the anterior commissure lesions. And the type 4, type 5 dissections came much later. So every surgeon will go through this. He will understand which cases to access, which cases can be resected properly, and then move on to more challenging cases. Dr. Srivastava and I go a long way, and we both have understood how we have learned this surgery, and the way we are practicing it today is far different from what we learned. So everyone will reach that stage, but it takes time and effort and persistence. You'll be challenged with difficult access. You'll be challenged with the laser not reaching there. You'll be challenged with the laser not hitting the tissues that you want. But remember that if you persist, if you keep practicing, if you understand that the patient is going to be benefited with the laser, you will in time understand how best to deal with. So this is something that I felt I should share with you all. Going ahead, I am sure that all of you will learn about these procedures from the stalwarts such as Dr. Srivastava. They have developed now models which can be used for training, and I'm sure he can tell us more about it. I don't think there is anything more I would need to say. I thank you for a patient listening, and I thank Asim for the invitation once again. Thank you very much.
Thank you so much, sir. It was very good for us to understand the philosophy, and you have really pretty well nicely summed up everything for anybody who has to start laser surgery.
Thank you.
So we'll move on to the case presentation now. Diksha, you can please share your slide. And I'd like to call the examiners. We have Dr. Kaveri Kaketi. She's Associate Professor in Head Neck Surgery at B. Barua Cancer Institute. We have Dr. Amit Chirom. He is a professor in Head Neck Surgery at All India Institute of Medical Sciences, New Delhi. Dr. Shamit Chopra. He's a senior head neck surgeon at Patel Hospital, Jalandhar. And Dr. Shilpi Sharma. She's a senior head neck oncologist at Narayana Super Specialty Hospital, Gurgaon. And for the case presentation, we have Dr. Diksha Sharma. She is a MSH resident at B. Barua Cancer Institute, Guwahati.
Good evening, everybody. Should I start?
Yes, Diksha, you can please start.
Good evening, everybody.
Voice is breaking.
I'm audible.
You are audible, but your voice is cracking, I think. You are in good signal range?
Sir, is it okay now?
Yeah, this is good.
Okay, sir. So, start with. My patient is a 61-year-old male, resident of Puri, Assam. He's a rickshaw driver by profession. He presented to us with a chief complaint of change in voice since last 6 months, which was in the professor, force and character. It was persistent throughout the day, and there were no relieving or aggravating factors for this complaint. There was no history of difficulty breathing, difficulty swallowing, any history of blood in sputum, no history of foreign body sensations, food, or cough associated with swallowing. There was no history of recurrent chest infection, no history of neck swelling, or significant weight loss, or no history of any vocal abuse. The past history, there were no comorbidities. There was history of gallstone surgery in 2007. Coming to the addiction history, he was a chronic cigarette smoker and he used to smoke 1 pack per day for almost last 40 years, amounting to 45 years. And since last 4 months, he has reduced it to 1 to 2 cigarettes per day. He was an occasional alcohol drinker. There was no history of any smokeless tobacco. No history of any drug allergies. Coming to examination, on general physical examination, my patient had a good performance score, ECOG score of 0, and the vitals were all within the normal range. SpO2 was 98% under repair, and there was no audible stridor. On local examination, mouth opening of the patient was adequate with the inter-incisor distance greater than 35 mm. There was some blackish discoloration of the lips, and rest of the oral cavity and oropharynx were within normal limits. On the 70-degree Hopkins examination, there was an istroproliferative growth in the right 2 vocal cords extending to the anterior commission, just reaching the anterior end of the opposite cord with no involvement. And the cords were mobile. As we can see in video, both the cords were mobile. Other than that, the hypnotic sync was adequate for the patient. Bilateral ASPFS, arytenoid was free of the disease. No significant disease was seen in the base of the vallecula or epiglottis. Neck examination, on inspection, the extension was normal. Laryngeal framework was normal with no widening. There were no visible swelling, scars, sinuses, etc. On palpation, the inspectory findings confirmed. There was no laryngeal tenderness. Laryngeal crepitus was present. No palpable lymph nodes were there. The trachea was in the midline. On radiology, we performed the CCT neck from base of skull to the superior mediastinum, and heterogeneous enhancing thickening in the right vocal cord region was seen, which was about 1.9 to 1.4 centimeters. with involvement of the anterior
Come
commission.
to the radiology later.
Okay, ma'am. I'll come to my provisional diagnosis.
Yeah.
Okay, so according to my history and examination, with the positive points being the elderly 61-year-old male, chronic smoker, presented with a complaint of change in voice. And on examination, we found an ulcer-proliferative growth in the right vocal cords. So my most likely diagnosis will be a malignant disease, most probably squamous cell carcinoma glottis, the clinical staging of T1A, M0, M0.
First of all, you tell me, why did you take a history of recurrent chest infection?
Ma'am, without any aspiration history.
Is there any other history you took for to rule out aspiration?
Yes, ma'am. Any cough associated with swallowing of liquids or food?
Okay. And your patient is current smoker? He's still smoking or he is reformed smoker?
No, ma'am. He has reduced the number of cigarettes to 1 to 2 cigarettes in last 4 months, but he's still smoking. He's not completely stopped smoking yet.
Diksha,
Reformed smoker? Yeah, please ask.
yeah, hi. Diksha, good luck. And again, credit to the Varanasi team. And again, I hope we can have a good discussion today. Diksha, I have a couple of questions for you.
Yes,
You
sir.
mentioned that you have an ipsilateral vocal fold lesion, but it's extending up to the to the anterior commissure. You have staged
Yes,
on
sir.
the synopsis slide that you presented to Dr. Shilpi that it's a T1A. Is that
Yes, sir.
subsequent to some further examination? Because you were fairly clear and the image also shows us that it's going to the anterior commissure. Would you want to see what your staging is, revise it a little bit? Does anterior commissure involvement upstage your tumor? Anyhow, Dr. Shilpi, so normally involvement of the anterior commissure is on examination with flexible fiber optic endoscopy is fraught with misinterpretation sometimes. Sometimes it's a lobulated component that's covering the anterior commissure. But here you were fairly clear that it was involving the anterior commissure. Going back to your slides again, it seems that it would probably be upstaged to T1B, right? I don't think we're having her voice completely. Do all the other examiners also have the same no? Voice is breaking?
Yeah, it's breaking in between actually.
Yeah.
Diksha, does he have a supraglottis involvement? I can see some, whether it's a secretion or it's a lesion there. So how can you clarify that?
Dr. Diksha, we can't hear you. Hello?
Might have been signed out, I think. Well, we have a lot of trainees here. Yeah.
So,
Yeah, please go ahead.
yeah, sir, sorry, I lost the connection between. Sir,
No, we are not hearing your voice properly. I think there's a signal issue. Yeah. Diksha, we are not able to hear you properly. And I think all the examiners pointed out to that. So if someone has her slides, she could just share audio and someone could play her slides. That's the only option I can think of, right?
Hello?
Yes, ma'am, I'm just changing my connection. Sorry for the.
We have a reasonably large gathering. In case someone has any questions about history taking for early laryngeal cancer, we can try to address those questions. You can type it in the chat box and you could also ask the question.
Hello,
Yeah,
audible?
we can hear you, Diksha. Hopefully this time it will be better.
Very sorry for the disturbance.
No problem. Please answer the question. Dr. Amit was asking you a question, and I think the prior answer is also pending.
Yes, sir.
Yeah, frank anterior commissure involvement, would it upstage your tumor?
Yes, sir. With the anterior commissure involvement, there's always a chance the thyroid cartilage is devoid of the inner perichondrium, and almost 20% of the diseases with anterior commissure involvement present with thyroid cartilage erosion. And for differentiating that, the MRI is the most sensitive scan that we can see, but there's always a chance of upstaging the disease. Also,
Let's stop at that. Let's stick to clinical pearls only. Dr. Amit had a question that he was concerned about some ventricular involvement. As you can see, the false vocal cord is tethered a little bit. It seems that the ventricle is not exactly ballooned, but do you want to address that? Is the false vocal cord involved also, or is it only the two?
False vocal cords, cords are mobile only both.
Yeah. So you can have mobility with another subsite involvement also. But to answer the prior question that I was asking you, it was more about clinical involvement of the anterior commissure. Of course, all of us know it can get upstage to higher stage disease. But if you're reporting anterior commissure involvement on clinical examination, it becomes a T1B by default. And therein you can go in and then, of course, do your investigation. Dr. Shilpi was asking you about evaluation for aspiration, and you mentioned a trial water test, right? What are the volumes that you typically use for the trial water test, and what are the sensitivity and the specificity associated?
I'm not aware of. Sorry, sir.
Not hearing you. Could you again try to be a little louder? Maybe speak slowly.
I have not read about this test.
Okay, so but you kind of answered that question, right? You mentioned that the patient was not having cough on liquids, and that's a simple chair side swallow test. Some people use anywhere between 50 and 100 ml. 75 ml is also commonly used, but sensitivity and specificity are poor, which is why you typically go to some further testing to be able to elucidate what kind of tumor your patient has and whether it's causing laryngeal dysfunction. Why don't we move on if the examiners don't have any other questions about examination?
So now what is your stage?
Ma'am, I would like to stage it I stage 1A N0 M0 because opposite cord involvement I cannot appreciate in my examination, so there's definitely a chance.
You mentioned that it's reaching anterior part of the left cord.
Ma'am, it's just reaching but not involving. This is, ma'am, in any way, in anterior commissure involvement, I meant it like that. That is just reaching, but as per my 70-degree optics, I could not appreciate any frank involvement of the anterior part of the opposite cord.
So what would you like to do next?
And next, I would like to consider radiology for the patient to confirm my findings and to get to know the extent of the disease. And after my radiology, I would like to plan the patient for a MLS examination under general anesthesia.
Why do you want to do MLS under general anesthesia?
Firstly, ma'am, map the whole disease to see some hidden areas which I'm not able to appreciate, to see if there's any subglottic extension, and the other hidden areas like the ventricle, and basically examine the other areas. Also, ma'am, I can have a tactile sensation and feel for any abnormalities in any suspicious areas. And also, ma'am, I can plan the patient. I can take a biopsy under general anesthesia since it's involving this cord area. It will be better to take the biopsy under the general anesthesia.
Would you do the radiology before the examination under anesthesia, or would you do it the other way around?
I would also prefer to do radiology before the examination under anesthesia.
Why don't we look at your radiology? I believe you have a slide on that.
Yes, sir.
Yeah, please go ahead.
Yes, so this is radiology.
Yeah. So you want to explain it?
Yeah.
Yes, sir.
Yeah, please explain.
Explain the slide, Diksha.
Here we can see there's some irregular thickening involving the right vocal cord, and some enhancements can be appreciated in the anterior commissure also. The left side seems to be relatively free, and no signs of any cartilage erosion we can see. And in my the scan, the whole scan, there was no nodal disease, there was no paraglottic spread involvement or pre-epiglottic space involvement.
So what are the limits of CT scan in this case?
Sorry, ma'am. The limitations?
Not the limitations, the limits. So basically,
Okay.
will it be the neck CT, or would you like to image the chest as well?
Ma'am, in this case, in the case of T1A glottis, I just we just did a CT scan neck from the base of skull to the superior mediastinum, and we did a chest X-ray for the chest. Considering that in early glottic lesions, the distant metastasis rate is quite low, less than 10%. So, and the patient also had some financial issues. So we sufficed with the preliminary investigation of chest X-ray to screen.
Is the patient a heavy smoker as per the criteria?
Yes, ma'am, and so also to look for any COPD changes due to the smoking habits.
And what is the incidence of synchronous primary in a laryngeal CA?
Is, ma'am, about 10 to 15%.
If you have a patient who is a heavy smoker, it's a good idea to screen the chest when you are doing CECT neck, right? You
Yes,
give HRCT of the chest simultaneously also. It will not be very expensive, I guess. So we are not expecting distant metastasis from the region, but in any case, there are recommendations that if the person is heavy smoker, you should screen the chest to rule out lung primary.
Okay, ma'am.
Go ahead.
Diksha,
Regarding
as you
this,
said,
yeah, please, Dr. Kaperi, go ahead.
Diksha, as you said, there are limitations of the CT scan in this kind of a disease. So what are the limitations of the CT scan? And what are the limitations again, or the demerits of assessing the cartilage erosion in a CT scan like this?
Generally, the accuracy of CT scan to detect a cartilage erosion is not very high. The most sensitive investigation for cartilage erosion is doing an MRI. It has an accuracy of 88% versus CT scan, which has an accuracy of 57%. And this believed to understage the disease, understage the cartilage erosion. And other limitations Ma'am, an MRI scan would give us a better picture about the paraglottic space involvement, about the vocalis involvement. So this CT scan is not very sensitive for detecting early cartilage erosion.
So you do you routine? Sorry, Dr. Schmidt, please go ahead.
So, are you saying that your initial recommended investigation for assessing early glottic cancer would be an MRI? You just mentioned cost constraints. We agree with that. Typically, doing two cross-sectional imaging tests, other than using it as a problem-solving tool, is not done. So, are you advocating an MRI over and above a CT for initial investigation?
No, ma'am. Actually, we generally first go ahead with the CT scan only, and this MRI can be used, as you mentioned, as a problem-solving scan when we are doubtful about the cartilage erosion in those cases.
So there are some criteria on the MR which kind of help to resolve what Dr. Kaberi was asking you about. Have you read about criteria of sclerosis? Have you read
Yes.
about, are there any specific criteria that you have on MR that help you resolve if a CT is not very clear on that?
Yes, there are certain, there is a Becker's criteria which has 8 points, and among them, sclerosis is said to be the most sensitive indicator, and erosion and lysis and extralaryngeal spread is found the most specific indicator, and there are there are about 8 points which tumor adjacent to the non-ossified cartilage, serpiginous contour, cartilage blowout, bowing of the cartilage.
So it's good you know about the Becker's criteria. I think one thing that we'd also expect you to know is variable patterns of ossification. It matters a lot in terms of gender, prior laryngitis, the age of the patient, which end up deciding for you whether or not there is some cartilage erosion which is subtle, or whether or not you're just dealing with variably ossified cartilage in that area. Okay, so did you...
Sure. Okay, can I just ask one question, Dr. Shamit?
Yeah.
So why don't we do MRI as an initial investigation in CA larynx?
Firstly, the availability of the CT scan, the cost, it is more cost effective.
If you have a tongue cancer, you will do MRI, right? You will not do CT scan.
No, ma'am, I will first go ahead with the CT scan only. MRI will.
So I'm asking you why MRI is not the preferred modality as a first initial modality, even if you have all the facilities, patient does not have any money constraint. Or you think anything can be done?
Because CT scan provides us with a better resolution, ma'am. The minimum cuts that we can get on a high resolution CT scan is 0.6 mm, and generally in larynx we use 1 mm cuts, and we can see all the levels of the larynx and assess and stage the disease.
And MRI, we can see with MRI also, no?
In MRI, the minimum cuts we can get is 4 mm, and there are chances of missing some important findings.
Otherwise, any other drawback?
Ma'am, CT scan, if the patient has to be planned for radiation and radiation treatment, it can be helpful as an initial investigation.
नहीं, आजकल तो PET CT fusion भी होता है, MRI fuse भी होता है. So basically, MRI tends to overestimate the disease. It is may not be very accurate. Why? Because for MRI, it is like a time-consuming procedure. It's not like CT. So CT can be done quickly, so that because the larynx is a structure which moves with deglutition. It's very difficult for a patient to stay in that position for long when the MRI cuts are, being taken. So with the swallowing movement and all, it moves. So it may not be accurate. You may get a kind of overestimation of the disease burden if you're looking only at MRI. So that is why CT is the preferred modality. But yes, it comes into picture whenever we have a problem related to the cartilage erosion, and all these things if we have to.
Yes, ma'am.
Okay, go ahead.
So Diksha, in your provisional diagnosis, you have mentioned directly that it's sort of a malignant growth. So how did you come to that diagnosis, and what may be the other differential diagnosis of a vocal cord lesion?
Ma'am, my first provisional diagnosis was malignancy some indications in the history and examination. For one, it is an elderly male who has a smoking history of about 40 pack years, and he complained of change in voice, which was persistent throughout the day, and there were no associated relieving or aggravating factors. And also, on examination, we found an ulcer proliferative growth. And so, my most likely diagnosis would be in an elderly male with positive history of smoking would be malignancy only. Other than that, ma'am, these lesions could be some pre-malignant lesions like dysplasia or dysplasia, erythroplakia, leukoplakia, and these could be some non-neoplastic lesions, which could be due to some infective focus like tuberculosis, some granulomatous diseases, any fungal infection. It could be inflammatory due to chronic irritation. We have hyperplastic laryngitis, in which there is a hyperplasia, or atrophic laryngitis, and there could be something like that, and some contact ulcers with some fibrosis.
Okay. Go ahead. Any more slides do you have?
No.
Okay.
What was the biopsy?
The biopsy, ma'am, came out to be squamous cell carcinoma.
Okay. So what is the stage now after doing everything?
It will be the clinically T1 A N0 M0 and stage 1.
You confirm that it was not going into ventricle, it was not coming on to the opposite cord.
Yes, ma'am. After taking the patient under for MLS examination, we screened the whole area and we palpated, and after that we staged the disease.
What would you do next?
So what do you see exactly in your MLS assessment?
Now, in MLS assessment, we will look for any the hidden areas, the subglottic if there's any subglottic extension.
Hidden areas like?
Yes, sorry, ma'am.
Hidden areas like, for example?
Yeah, the subglottis, ma'am. The anterior commissure can be better visualized under general examination. The ventricles, then the ma'am adjoining area like the apex of piriform sinus, the laryngeal surface of the infrahyoid epiglottis, and the postcricoid region. We can assess these better in an MLS examination.
Okay. And anything else do you see in MLS? After he's saying seeing the hidden sites and probably taking a biopsy, right? Anything
Yes,
else?
We can.
Sorry?
We can, ma'am, see the mobility of the arytenoid by palpating it, and you can see assess the requirement.
Sorry, and how? What is the significance of assessing the arytenoid mobility?
Ma'am, because if it is not mobile, then the cord becomes fixed and it upstages the disease. Also, it changes the treatment plan for the patient if the cord is fixed.
And arytenoid mobility.
Yes,
Cord is fixed, you can know with your Hopkins also. So the added,
yes, ma'am. It
which
changes
you'll
the
get.
treatment.
Yes, yes.
So Diksha, we've spent a fair bit on your slides. I think we'd like to hear you. Do you have any other slides or this is it?
No, so no more slides.
Okay, so you can stop sharing so that we can probably get better audio.
Okay.
All right. So couple of things that concern me about the CT report. You reported two dimensions of the laryngeal lesion as 1.9 and 1.4 centimeters, correct? Now, even in the broadest of larynges, the distance from the free edge of the vocal fold to the thyroid cartilage is rarely 1.4 centimeters. which makes me think that probably the vertical extent of the tumor is concerned. I would revisit this report with the radiologist. I would go there and figure out what the second and even potentially the third dimension could be. Dr. Shilpi told you about tongue cancer, and normally we report the tongue cancer in 3 dimensions. It's more challenging to report a vocal fort cancer in 3 dimensions because for a glottic cancer, it begins and ends. The craniocaudal extent is virtually negligible, and it amounts to the thickness of the vocal cord for early cancers, right? But this 1.4 centimeter makes me think that it's probably more lateral. So this is probably a measurement that you'll have to readdress. We've already talked about the CT and the MR vis-a-vis their advantages or disadvantages. And for the sake of all the people who are in the audience, I think it's important to reiterate what Dr. Shilpi was asking you about and what Dr. Kaberi was reinforcing. We need to make sure that we have a preferred initial diagnostic evaluation in terms of cross-sectional imaging. And very simply put, there are 3 reasons why you do a CT as initial treatment, initial investigative modality: speed, the spatial resolution, and the cost. It's just easier to obtain a CT, and the fine cuts are something that you mentioned. I disagree with your answer on the MRI being 4 millimeters and not less than that. I wonder if there are radiologists in the audience, but if they're not, we can probably talk about the fact that you can get sequencing on the MR, which is much less than that. But for all practical purposes, a CT should be initial diagnostic evaluation for whatever we talked about. And you use the MR as a problem-solving tool, use your Becker's criteria, see whatever else you need, especially in cases where you're uncertain about involvement of a particular subset of the larynx. Is that clear?
Yes, sir.
Hello?
Yes, sir. Okay, sir.
Great. Regarding your evaluation under anesthesia, I would refrain from calling it an MLS every time. It's important to know that in the current day and age, we have very good imaging. I mean, in terms of the endoscopic tools that we have. So normally you'd use a combination of rigid endoscopes. They offer you the advantage of visualizing the lesion initially in 2 dimensions, but utilizing various angled endoscopes, you can actually get a much better idea than you could with just looking at it through a microscope. By all means, look at it through a microscope also. It's always good to have a microscope in the room at the time that you're doing it. But can you tell me about the angles of the endoscopes that you need to evaluate all the hidden areas that you're talking
For evaluating the larynx, we use 70-degree endoscope. But for anterior commissural, we can use a 30-degree endoscope for better visualization.
So one of the hidden areas that you did not mention was the undersurface of the cords. And it's important to know that if your institution has the option, you can use a 120-degree facing up endoscope to visualize that area. And it has proven fairly helpful in our practice, especially when you're deciding between TLM or some other modality. Hidden areas you covered fairly okay. I think that regarding assessment of arytenoid involvement, one thing I would add is that you use a velvet tip long suction, and then you try to roll the vocalis out of that area. So it will give you some idea about whether or not the vocal ligament is involved, and further on the thyroarytenoid is involved. And of course, your radiology will give you a clue. You were correct in mentioning that radiology should be done before EUA, and that's important also.
Okay, sir.
So you took a biopsy and it's squamous cell carcinoma. Do you recollect the differentiation of the tumor? What differentiation was it?
Okay, sir, about what differentiation?
Sorry, your voice is breaking.
Sir, I am not sure about the differentiation. I don't recollect.
All right. So it seems like a fairly unifocal disease, right? The other cord is uninvolved, and you've established that.
Yes, sir.
So once you've established that on examination under anesthesia, you're truly dealing with a T1A, but a relatively extensive T1A. After making another trip to the radiologist, making sure that that 1.4 centimeter is not something that you need to look at. Let's assume that it's confined to the membranous vocal fold. Okay.
Yes, sir.
Did your CT show thyroarytenoid or vocalis involvement?
So the CT scan, it did not mention not very sensitive investigation for
All right.
vocalized muscle and motor function.
So now you have all the information that you need to be able to discuss with the patient, correct?
Yes, sir.
Yeah. How will you counsel the patient and his caregivers about further treatment courses? What options will you give?
Yes, sir. In a stage 1 disease like this, we have the option, like we will discuss with the patient regarding the treatment options, which is the surgical versus non-surgical. And so in surgical also we have the transoral laser section of versus partial laryngectomies. But partial laryngectomies for a T1 disease are fairly a morbid procedure. Our main point of discussion will be between the transoral laser surgery and the radiation therapy. Um, um, uh, in the literature, mostly with the new recent meta-analysis also, transoral laser surgery has a slight edge in the loco-regional control versus the radiation therapy. And there are few advantages with respect to some factors. However, if in radiation therapy we have the advantages of a superior voice quality, we will give these options, treatment options to the patient. We'll see what the patient wants. So basically, among these, we can make a decision on based on some factors. Like there are some tumor factors.
Patient says, Doctor Saab, आप बताओ जो करना है, आप बताओ which one is the best treatment for me. Then how will you counsel him?
Okay. Ma'am, we will assess this regarding some factors. Like we'll see the tumor factors, the stage of the disease. In stage 1.
About this patient.
About this patient, ma'am.
What will you prefer? And basically back it with your answer points.
This patient has a cord lesion extending to the anterior commissure. Because of the anterior commissure involvement, I would plan the patient for a radiotherapy. Because of the anterior commissure involvement, because for transoral laser surgery 1, in anterior commissure involvement, exposure can be a problem, and margins, taking adequate margins can be an issue. Other than that, there is some complications like web formation in the glottic area. And with anterior commissure dissections, the voice quality is also inferior to
So anterior commissure is free in this patient. Otherwise, everything remains the same. Then what would be your answer?
Then, ma'am, I would definitely go for a transoral laser dissection in T1A diseases whenever feasible. This is the best treatment for T1A glottis because it has a good control rate, overall survival, and a very high laryngeal preservation rate with respect to radiation therapy.
See, with this patient, no, even if the anterior commissure is not involved, the lesion is involving almost whole of the cord. So even if you have to take some margin, so your margin will be in the anterior commissure area, even if it is 2 millimeter or 3 millimeter. Do you think that voice outcome will be superior with laser in this particular patient?
Voice quality is definitely superior with radiation therapy, but then, ma'am, that depends on patient's occupation and demands from the voice. If the patient has very high demands of voice quality because of his occupation or anything, then we can take the patient for radiation therapy also. But in terms of the local control rates and other benefits of transoral laser surgery, like it minimum post-operative stay, lesser complications, lesser post-op period being better, smoother recovery, the post-op period, lesser laryngeal edema, availability of a histopathological specimen for assessment, and the total duration being less, it being cost-effective modality, and due to less post-operative edema, if there is any recurrence, we can detect it earlier. Also, most importantly, in cases of recurrences, we have more salvage options in terms of laryngeal preservation modalities. with respect to these benefits in a mid-cord lesion, which is free
Which
to
is
move
not
and
cord lesion. What is the
Sorry?
lower extent of your tumor in this patient?
Sorry,
Is
ma'am.
it reaching? What will be the lower margin of resection in this patient? Can you just show us the images again? Or maybe forget it, just tell us like that. Is it a mid-cord lesion?
No, ma'am, this one is not a mid-cord lesion. In case, I think you mentioned if there was no anterior commissure involvement. If there is anterior commissure involvement, I will.
Diksha,
Yes.
what Dr. Shilpi was asking, in this case, anterior commissure involvement is okay, but in case anterior commissure involvement was not there, but the entire vocal cord was involved, no? This is not a mid-cord lesion, right? The entire cord was involved. And what what Dr. Shilpi was asking, as you cited the meta-analysis which favored a better vocal outcome, voice outcome with surgery, do you think type 1, 2, 3, 4, all the types fare similar in voice outcome? Because you are going digger, you are digging deeper and deeper, no, as the types goes down and down. So
Yes,
that was what Shilpi was asking.
So all those advantages you are quoting, they're classically for a mid-cord lesion. It's not that, black and white that you can put. You have to see your patient. Whenever you get a patient in exam, you have to see your patient and then speak. Even if anterior commissure is not involved, in my opinion, this is quite extensive lesion. You have to, take lot of tissues. You really have to talk to the patient that voice quality is definitely going to be inferior as compared to radiation therapy.
So,
You
Diksha,
can take others' opinion as well. Dr. Shamit, Dr. Chiram, they can also comment on it.
So, I have a question for Diksha. Can you quote us some evidence or tell us your broad understanding from literature which tells you that voice outcomes are worse after a particular advanced cordectomy? Dr. Kaberi gave you a big hint. Are you aware of the European Laryngological Society of Classification of Cordectomies?
Yes, ma'am. Yes, sir. In literature, it is reported that the voice outcomes in according to the ELS classification in type 1 to 3 cordectomies is better than those like in greater than 4 type cordectomy.
So even if you compare it with historical controls which received radiation therapy, you know that type 1, 2, and 3 will have better voice outcomes or equivalent voice outcomes with radiation therapy. Once you start pushing the envelope, do a type 4 or do a type 5, at that time your voice will get compromised. That's what us examiners are getting to.
Yes.
Also, are there any other tools in addition to what we have discussed which help you assess whether or not anterior commissure involvement can be addressed surgically? You've had two very elegant talks. One is the philosophy that Dr. Pai laid out. One is, of course, the exposure. And of course, are there any other factors in anterior commissure involvement disease which help you decide, no, I can take this patient up and probably achieve the same local control with surgery as well?
Might be the exposure.
Yeah, please go ahead.
Addressed with the adequate margin.
We can't hear you, Diksha.
Ma'am, can you hear me?
Yeah, better.
Yes, ma'am. I think the exposure is adequate for the patient. We can like address and visualize the
Yeah, so good. So that's the first point we were coming to. Dr. Srivastava just did a talk on laryngoscore and even mini laryngoscore.
Yes, sir.
Make it a practice. You might not choose to use the laryngoscore. It's up to your understanding. We use the mini laryngoscope score these days because the main laryngoscore ends up being a little tedious when you have a busy clinic. But there are multiple other criteria you could use. People use CL all the time. People still use MPS for some kind of predictor of laryngeal exposure. And a lot of authors have done elegant work.
Yes.
Have you heard of a classification by our Italian colleagues on the sub-classifications of anterior commissure involvement?
No, sir, I'm not aware.
Okay. Have you heard of horizontal versus vertical anterior commissure involvement?
Sir, no, I have not heard about it.
So horizontal is more the superficial spreading type. And in addition to the laryngoscore and all the other criteria that have already been discussed, you might consider that patient for a TLM with anterior commissure involvement, and the outcomes are decidedly much more improved. However, Peretti and his colleagues have shown us, and it's been presented a few times in our settings also, that vertical anterior commissure involvement is concerned, which is what that 1.4 centimeter is really concerning. It seems to me that there is a possibility that you might have vertical anterior commissure involvement, because again, the cords were mobile and that's okay, but sometimes fibrosis in that anterior part or involvement or incorporation of limits, as your other examiners have told you, is something which we might not be able to address. So beware of horizontal versus vertical anterior commissure. It's been subclassified very well, and we can quote the papers. The meta-analysis that you're quoting, can you tell me what meta-analysis we are quoting?
Sir, the one for cordectomies.
Yeah, well, we quoted a meta-analysis when you said the voice outcomes are better. And I just wanted to make sure you were quoting the meta-analysis that we think you're quoting.
Voice outcomes better with the laser surgeries, sir.
No, so you quoted a meta-analysis, but you did not tell us which one. I just want to make sure that you know which one. So the one that we tend to quote fairly often, and my co-examiners can tell me if there's an update, is the Higgins meta-analysis. More than 8,000 patients, T1 disease, and laryngeal preservation rate was better. I think it's an important consideration when you take up a tumor that's involving the entire vocal fold also. But you pay due emphasis to what my co-examiners told you about really counseling the patient very well about voice outcomes. Type 4 and higher cordectomies, the so-called extended cordectomies, will typically have a poorer voice outcome. And especially when Dr. Shilpi asked you about the posterior limit of the resection, if it ends up incorporating part of the retinoid more than the vocal process, then you're also dealing with a swallowing problem. So you need to be very careful when you counsel these patients. Okay?
Okay.
So tell us, what are the different meta-analyses which have looked at oncological outcome between radiation therapy and laser surgery?
Yes, ma'am. There are some previous meta-analysis by Dina Polly et al., by Van Gogh et al., Remeltz et al. There have also been some recent meta-analysis by MF Vakulik, Campo et al. There has also been a paper from Kidwai, which shows higher control rate as well as laryngeal preservation rate compared to radiotherapy. There has been a paper by Steiner also.
Were included, and what was the kind of patients which were included in those? Where it is better?
Hello, ma'am. Yes, ma'am, early glottic patients were included in these.
T1, 2. Early glottic means what? It can be T1A, it can be T1B, it can be T2, right? All.
Ma'am, most of the patients included all. There was one paper by Campo et al., which included only T2 lesions. And this paper from Kidwai included T1A and T1B lesions. T2 lesions, we have one paper by Campo et al., which also found significant.
So you tell me, if you are quoting Higgins meta-analysis, so what was the primary endpoint? What was how many patients were involved? How many studies were included? And what was the outcome? Whenever you are quoting any research, any meta-analysis, you have to tell properly. So that you have to know. So majority of the papers by Higgins and by a few others, there is one from the Finland, I guess. So they all say that oncological outcome, they are equivalent for early glottic cancers in terms of radiation and laser surgery. There is one meta-analysis by, I think, Guaquimeres, which says that outcomes are more favorable for laser as compared to radiation. But again, there are a lot of problems because these are all retrospective studies. We don't know. There is, many times there is selection bias because probably the patients were taken up for surgery because they were more favorable tumor characteristics. So you can quote them, but it's all, you have to tell them the limitations also. You have to keep those things in mind. Is there any randomized control trial which has looked at?
I don't recall.
There is one randomized control trial. Number of patients were small, only 56, I guess. They were more in the laser arm and less in the radiation therapy. And they also found the similar oncological outcome.
Okay,
It was published in 2022. So you have to know all these things by name and what were the outcomes. You can't say one meta-analysis showed that.
Yes, ma'am.
Similarly, for the voice outcomes, you have to know all. Especially when you are quoting that in one meta-analysis, this was better than this, then you have to know it.
Yes, ma'am.
So classically, we say that voice outcomes are superior with radiation therapy, but here you are saying other way around, right?
No, ma'am. The voice quality, according to literature, has been superior in radiation therapy only.
Is there any temporal relation also with the voice quality? Like with laser, is it something like that it is bad initially and then gradually improve, or it's other way around?
Yes, ma'am. Laser usually the early voice quality is said to be inferior, and in literature it shows that long-term quality of voice, like more than 2 years, is found to be comparable to the results of radiation therapy.
And with radiation?
Radiation immediate weak is low but improves gradually, temporally, as you said.
Okay.
So we've established, Diksha, based on this discussion, that for a disease where oncological outcomes are similar, you want to focus on functional outcome. And for T1A disease, the predominant functional outcome is voice, right? So what tools do you have to assess voice pre-operatively and post-operatively so that you can know whether or not you caused the morbidity or prevented them?
Yes, so we have some tools, like we have some questionnaires to assess the quality of life associated with the voice, like the voice handicap index. We have the VHI 30 and VHI 10. We have a voice questionnaire also, and then we have some perceptual tools like the GRBA scale, which can give us an idea about the perception of the voice with the patient. Then, sir, we have some tools in form of the acoustic analysis, in which we can see the character of the voice. We can see the jitter and shimmer. We can also assess the maximum phonation time for the patient, and then compare it post surgery.
So comparing these parameters pre and post-op, in case you're doing laser or whether you're doing radiation. So I would say pre or post-treatment would be essential in helping you predict objectively what you're dealing with. VHIs are subjective indices.
By patient.
VHIs are subjective. Typically, if you are in a center that has acoustic analysis, also has certain more objective criteria, including a video strobe. Can you tell us a little bit about video stroboscopy and its utilization in the pre-operative or the pre-treatment setting?
Stroboscopic basically helps us assess the vibration of the false epithelium, when the mucosal, it's based on the Talbot law, and you can see the mucosal layer sliding over the angle of the vibration.
Voice
There
is
is an epithelial lesion. We can I'll have to read more about it.
So, yeah. So when you talk about video stroboscopy as a tool for pre-treatment assessment, you should also talk about some light-based aids that will help you. And again, we have an expert. He is still in the audience. Dr. Rakesh is there. Is there anything else? We are moving away from voice now. Okay. Is there any tool that can help you map the extent of your resection in case you're planning laser surgery in the preoperative setting? You said video stroboscopy is one, and we agree with that. Absence or presence of the mucosal wave, the presence of the amplitude, and everything else that you typically use for assessment. But is there any other light-based tool that we can use?
Yes, so we can narrowband imaging, which can help us map the disease if there is any submucosal disease, or we can do OCT optical coherence tomography, which is a cross-sectional view of the cord, and we can map the disease better. We can also do contact endoscopy. These are some tools in the form of narrowband imaging. Narrowband imaging.
What do you see in narrowband imaging?
So in narrowband imaging basically is based on the principle of neoangiogenesis, which there are lights which are absorbed by the globin. We can appreciate the vascularity in the lesions, and for laryngeal lesions, it has been used very widely, and there has been a scoring system based on that also to differentiate between benign and malignant lesions.
So this is a malignancy you are suspecting. So what is the pattern you will see in narrowband imaging? Because most of the studies of narrowband imaging is mainly done in larynx only.
Yes, so there is a scoring system, sir, according to which the type 5 patterns, the intraepithelial capillary loops that are present, they signify presence of malignancy. Type 5 knee scoring.
Knee classification type 5 is the one which you
Yes,
are.
sir. Yes, sir.
So in this patient, what is the outcome you are achieving, you are expected to achieve after any mode of treatment?
The first outcome will be the local control only that has the outcome.
So how much percentage we are trying to achieve?
Greater than 90%.
Okay. So once we have done the treatment, how do you follow up these patients?
Can I just ask, before we move on to follow-up, can I just ask one question?
Yes.
What are the unfavorable features in any patient where if they are present, then the prognosis is slightly, will be less than 90%, there are high chances of recurrence?
Ma'am, in this case of early glottic cancer, ma'am, anterior commissure involvement, where we are not able to take margins, and sometimes even radiotherapy also, there is possibility of a cold spot there. Then, ma'am, bulky tumors with impaired cord mobility can also be poor prognostic factors for in case of early glottic lesions.
So is there any factor which is present in your patient which makes it slightly unfavorable?
The anterior commissure involvement, ma'am.
So, of course, we achieve more than 90% in early glottic cancers, but that is in general. Whenever there is an adverse factor, it may be slightly less. This patient might have a chance. Why is the inferior outcome with radiation? So,
sorry,
ma'am. Okay, you mentioned that we might not have achieved the good margins, or exposure may be difficult. We might leave behind the disease. But why?
Yes,
see, anterior commissure is a bad prognostic factor. With
yes, ma'am. Ma'am, because when we give the radiation beam from laterally, there is a chance of developing a cold spot in that area. And there is always a chance of lesser dose delivered there. That is it counts as an unfavorable factor.
And also because sometimes they may be understaged. They
Yes,
might
ma'am.
they might be T3 lesions.
Yes, ma'am.
There may be early cartilage involvement which we have not detected, and there is no way we can detect otherwise. when we are doing radiation therapy.
Yes, ma'am.
Okay.
And Diksha, apart from the tumor factors and the tumor factors as Dr. Shilpi has mentioned, is there any other high risk factor in your patient, or you need to counsel this patient, which might later on be a high risk factor for recurrence in your patient?
Ma'am, patient is still smoking, and
Yes. So do you think counseling in this aspect is important, because patient was still smoking when he presented to you, right?
yes, ma'am, definitely.
And I asked earlier also, you did not answer. What is the definition of reformed smoker?
Ma'am, patient has stopped smoking for at least 1 year.
One what?
1 year, ma'am. 1 year.
1 month.
1 year, ma'am. 12 months, 1 year.
Okay. Anything to do with the number of cigarettes consumed?
Yes, ma'am. There has been a paper, ma'am, by Pellucci et al., which states that the risk of developing cancer increases with the duration and the number of cigarettes
No,
smoked
no.
per day.
I'm asking,
And
is there any number of cigarettes consumed also when you define a reformed smoker, or it's just the duration?
no, ma'am, less than 100 cigarettes.
At least 100 cigarettes.
Yes, ma'am.
Patient should have consumed at least 100 cigarettes, and then he should have left at least for more than a year.
Yes, ma'am.
Okay.
Yes.
Okay. Okay, coming to follow.
Yes, ma'am. We'll follow the initially we'll follow up the patient with for 3 monthly for the first
We have lost you again, I guess.
Diksha, we can't hear you.
ma'am, can you hear me?
Yeah, better.
Yes, ma'am. We'll follow up this patient 3 monthly for the first years, followed by 6 monthly follow up for 5 years, and then followed by yearly follow up after that, after 5 years.
Okay, just before follow up, just one question. How would you address the neck in that patient of yours?
Ma'am, since it is a T1 aglottic disease, and the risk of nodal metastasis is very low in such patients, it is about 1 to 4%. So I would not address the neck unless there is some indication of neck metastasis in this patient.
Even if in both surgery and radiation, or in radiation you want to include that field in the
No,
neck?
ma'am. No, ma'am. We want to minimize the exposure to radiation in cases. So I will not now radiate the neck in this case.
Okay.
The disease is reaching it's involving anterior commissure. It's just bordering on the opposite cord. You don't know whether your anterior commissure might be involved. I think it's a good idea to include the neck. Radiation therapists, they will include the neck, I guess, in this kind of. It's not exactly, that small T1 mid-cord kind of disease.
Yes, ma'am.
So agree with the points that have been made. I think when you have involvement of the anterior commissure, there is data for lymphatic vessel spread the same way that the anterior subglottic wedge and the Broyles ligament facilitates spread. So you will need to, if you're choosing radiation, then a lot of radiation oncologists with these days use carotid sparing IMRT, and they'll probably just radiate the central neck. I want to ask you a question, which is an extension of Dr. Shilpi's prior question. You only mentioned the clinic follow-up protocol. What would you do for follow-up of a patient with treated glottic cancer? Would you only do mucosal surveillance? Would you do mucosal with radiological surveillance? Would you do something else?
I would follow up the patient Endoscopic evaluation, if there are no signs of any suspicious disease, I I won't go for imaging, sir. If there are no signs, if you can see local regional control, clinical evaluation.
Yeah, so a lot of us would probably base that last point that you made on the treatment modality that was chosen. After
Yes, sir.
laser surgery, especially
Yes,
an
sir.
intensive resection, you would probably tend to have some radiology, so you can have some idea about some criteria. Are there some criteria that you want to highlight that help you in the post-cordectomy patient vis-a-vis radiology?
I'm not sure. After laser resection, there are chances of fibrosis and there are chances of fibrosis and some web formations. We might be able to appreciate. I'm not sure of the criteria, sir.
So general criteria on MR include diffusion restriction, even though they need a particular volume of disease to be able to show a diffusion restriction. There's something called ADC images. General criteria relevant to other follow-up head neck radiology can be applied to these particular cases. But I think a lot of us would probably adopt mucosal surveillance only for patients who had an early cordectomy. And in case you're concerned about deep margins, you ended up doing an advanced cordectomy, you tend to employ some radiology as part of your follow-up.
Okay, sir.
Any more questions, or should we wind 7:30?
Since he has been the heavy smoker and incidence of second primaries, metachronous primaries and lung are quite common. Not quite common, but as compared to the other primaries, it's more prevalent.
Yes, ma'am.
When you have surveillance, again, I think Dr. Shilpi helped you with that, so I'm asking prospectively. But what is the predominant pattern of failure in early glottic cancer?
So first will be the local recurrence, local regional recurrence.
So yeah, do you want to think about it again? So we classify recurrences in terms of their relapse locally, recurrently, distantly, or second primary. So which would be the predominant pattern of relapse in these patients after treatment?
Would be the second primary. The incidence is around 10 to 15%. For a second primary.
Yeah, I'm glad you corrected it. You had answered part of this initially.
Yes.
I think is the TMC Varanasi team here?
I think we can just wind off now.
Yeah, absolutely. So Diksha, I think we'll with the permission of the organizers, we'll wind up. You
Yes,
you tried well, and I think you answered more than half of the questions. Some satisfactorily. Like I'll just borrow words from my co-examiners as they pointed things out to you. If you're quoting literature, please make sure what literature you're quoting. If you are quoting modalities, make sure you know about the modalities. In an examination, you want to be in a safe zone. You don't want to quote things that you're not able to add on. Also, make sure you read your slides very carefully, and they should corroborate what you typically see with regard to the disease that you're presenting. There were a couple of discrepancies there, but good luck overall. Thank you. That's it from my side.
Yeah, otherwise, well done.
Thank you, ma'am.
So thank you so much everyone for joining. Thank you Dr. Prathamesh Pai sir, Dr. Rakesh Srivastava sir for the excellent lectures on the philosophy and the use of the laryngoscopes and the laryngoscopes. Thank you Dr. Shilpi, thank you Dr. Shamit Chopra, and thank you Dr. Amit Chirom for joining. And thanks a lot Kaveri, and thanks Diksha for the presentation. We'll meet once again after 15 days.
Thank you, Asim. Thank you for having us.
Thank you.
Thank you. Thank you so much.
Okay. Yeah.